السلام عليكم.
عليكم السلام ورحمة الله وبركاته.
ما شاء الله كويس، كيف الأمور؟ ما شاء الله 300 وما شاء الله العداد يحسب ما شاء الله. كويس.
الحين حتى اللايف شغال، اليوتيوب لايف.
كيف؟
اليوتيوب لايف شغال.
كويس ممتاز. ما شاء الله عليك. عبد الرحمن. دكتور ظافر الشات في انت تتحكم في الشاتنج ولا؟
Q&A only، ما في شات.
ها؟ طلع لي الشات انا هنا. راح.
تمام. لكن هذا فقط للباناليست يعني.
ايوه كويس ممتاز. الله يعطيك العافيه، جهود طيبه صراحه.
If you want to start, Dr. Maher.
Okay, Bismillah ar-Rahman ar-Rahim. Dear ladies and gentlemen, as a member of SASBIGN board, I am pleased to welcome you to this landmark symposium on celiac disease, co-hosted by the Ministry of National Guard Hospital in Al Khobar area, Imam Abdurrahman Al Faisal Hospital, as well by the SASBIGN, also Nestle Institution for Health, as well by the Nestle Company Celiac Association, as well Saudi Celiac Group. I am all the more delighted to welcome you as a chairman of the organizing committee to this first Eastern Province Celiac Disease Symposium. This symposium is aimed to know a new era of celiac disease like the genetics, autoimmunity, as well the immunology and pathology. Again, welcome, and let us start our talk by the president of SASBIGN, Dr. Muad Al-Atraiki, who will get the introductory talk for this great symposium. Please, Dr. Muad.
Okay, thank you, Dr. Maher. Assalamu alaikum wa rahmatullahi wa barakatuh. I will speak in Arabic and in English. السلام عليكم ورحمة الله وبركاته، حياكم الله جميعا. نيابة عن مجلس إدارة الجمعية السعودية لأمراض الجهاز الهضمي والكبد والتغذية لدى الأطفال بالمملكة العربية السعودية، نرحب بكم في هذا المؤتمر الذي يحظى برعاية من الجمعية وبرعاية من وزارة الحرس الوطني ممثلة في مستشفى الإمام عبد الرحمن الفيصل بمدينة الدمام. حقيقة نحن سعداء بعقد هذا المؤتمر الافتراضي. نتقدم بالشكر الجزيل حقيقة لسعادة الدكتور ماهر الهطلاني رئيس اللجنة التنظيمية لهذا المؤتمر، وبذل جهدا كبيرا مشكورا لإقامة وإطلاق هذا المؤتمر. وكما ستشاهدون كنوع من التغيير في الطرح في هذا المؤتمر، حقيقة تغيير كامل وليس الطرح التقليدي حقيقة، وهي مواضيع حقيقة مهمة جدا جدا لجميع الأطباء وأطباء الممارسين بشكل عام. Dear guests, dear healthcare providers, on behalf of the board member of SASBIGN, I would like to welcome everybody who's joining us on this symposium, the first Eastern Province Symposium about celiac disease. I would like to great thanks for the great effort of Dr. Maher Al-Hatlani, the chairman of the organizing committee for this symposium. As you know, this symposium, as Dr. Maher mentioned, it is accredited by 8 CMEs hours. Also, we have more than 2,200 registered healthcare providers. This kind of symposium has new things, new talks, new topics to be discussed, which maybe not discussed before, like in genetics, in allergy, or immunity. I would like to also, we are glad that to have our, speakers, distinguished speakers really who join us from National Guard and from other institutes. Thank you, Dr. Maher, again. Thank you, our participant for that one. It is yours, Dr. Maher, to start the symposium. Ala barakatillah. Thank you.
Thank you, Dr. Maad. Bismillah ar-Rahman ar-Rahim. Our distinguished speakers is Professor Majid Abdullah Al-Fadl, who will talk about the update about genetics and genomics of celiac disease. Professor Majid Al-Fadl is well-known distinguished speakers in the clinical genetics. He is running now as the chairman of the clinical genetics at the KMC National Guard Hospital in Riyadh. He is well known with many publications, ended by earning his professor degree in very young age. He has a lot of participation in discovering a new mutation and genetic disease in the kingdom. And really, as a SASBIGAN member, I'm so happy to introduce him and welcome Prof. Majid for this talk. Please, the mic now with you. Thank you very much.
Thank you, Dr. Maher, for this nice introduction. And thank you for the organizing committee and scientific committee for inviting me to present such a vital topic in the era of genetic and genomic, which is a celiac disease. So today I will just have some introduction about the classification of genetic disorders and where celiac disease belong to with this classification, and then we'll talk about genetic of celiac disease, and then how to investigate from genetic point of view for a patient with celiac disease. And again, also we'll go and discuss the recent update that discovered recently in the era of genetic of celiac disease. So, so to understand the topic, we should know that all of us formed from one cell. And this cell contains 46 chromosomes inside the nucleus and encoded 30,000 genes. This what we discovered, but we know that we have maybe more than that. And we link to human diseases currently around 5,000 diseases. And this is from Statistic. I entered 2 years ago, and I found that we linked to human diseases around 4,274, while yesterday it is increased to 5,705 approximately. So this means during 2 years, we discovered 1,431 disease as a new disease. And imagine these diseases all need to be characterized and studied and explained. So really we are in the era of genomic nowadays. So to understand also the subject, we need to understand the types of genetic disorder. So the types of genetic disorder, we have chromosomal abnormality like Down syndrome, Turner syndrome, Patau syndrome, where which is the trisomy 18, and single gene disorder like Duchenne muscular dystrophy. And this kind of disorder is subdivided in two major categories, which is clinical genetic or dysmorphology, and biochemical genetic, which is and inborn metabolism. And as a geneticist, you need to understand all of these in order to be a geneticist. But the difference, for example, for single gene disorder, like Marfan syndrome, like sickle cell anemia, like thalassemia, like Duchenne muscular dystrophy, while the single gene disorder due to abnormal metabolism like phenylketonuria, galactosemia, tyrosinemia, and so on. The third category, which is our talk today, is complex genetic disorder. And complex genetic disorder, this is not a problem in the chromosome and not a problem in the gene. So it's interaction between environment and the gene, and we call it multifactorial. And celiac disease belongs to this category, which is multifactorial or complex genetic disorder. Other examples of complex genetic disorder include birth defect, diabetes, cancer, obesity, cleft and palate, congenital heart disease, and so on. In this disorder, you find around 5% is a genetic, and the end is multifactorial, including environment and other factors contributing to the environment. So the modality of identifying genetic abnormality, it's either cytogenetic technique, which is karyotype, FISH, and CGH microarray. So if you want to diagnose a patient with Down syndrome or with Turner syndrome, you need to order these test karyotyping, which is the oldest technique discovered in 1960, where they usually make it take the blood and make it to the slide, and then stain it with Giemsa stain, and then see the structure of a chromosome and count. So for here, for example, if there is a 3 chromosome here, this is a trisomy 18. If it is a 3 chromosome here, it is a trisomy 21. So if it is a 3 chromosome here, it's trisomy 21, and here XY indicate this is a male. If it is XX, indicate a female. While in FISH, which is fluorescence in situ hybridization, you want to check a specific region in the chromosome. So you ask for a probe or buy a probe and check for that specific region. For example, you want to check for Prader-Willi, you buy the probe for 15q11 and check if it is deleted or duplicated or normal. While CGH microarray will detect subtle deletion or duplication in the chromosome. Now we move to molecular technique. So you remember when I start my talk, we have single cell. This cell have 46 chromosome. You test this 46 chromosome by FISH or chromosomal analysis or CGH microarray. If you want to check the single gene itself, then you need to go to different tests. So initially, and the gold standard previously, it's Sanger sequencing, and we make it for single gene testing. For example, I am sure this patient has, let's say, sickle cell anemia, so I will check for HBB gene. Or I am sure that the patient has galactosemia, so and the enzyme deficient, the galactose 1-phosphate uridyl transferase is deficient, then I will check for GALT gene. However, in 2008 and 2009, we started seeing next generation sequencing coming to the era. So gene panel is introduced, where you can check more than one gene by one chip, and then whole exome sequencing, and finally whole genome sequencing. Again, one of basic concept today is the gene. The gene, as we mentioned, it's a heredity unit of the cell, and any defect in the gene, we call it pathogenic variant or a mutation. And the gene has 2 copies. Each copy we call it allele. So if an allele are the same, we call it homozygous. If it is one allele is normal and the other is abnormal, we call it heterozygous. If the allele in X chromosome, we call it hemizygous, or Y chromosome, we call it hemizygous. If the allele is abnormal but 2 different variants, this we call it compound heterozygous. And this is the structure of the gene. The gene is formed from exon, which is the functional part of the gene. You remember we said whole exome sequencing. So whole exome sequencing only scan the exons in the gene, which is functional part of the gene. And interestingly, this is account only 1% of the whole genome. And then intron, we have and boundaries, which is the supply site. And then we have the promoter, which is the head of the gene, and tail of the gene. So this is the gene. The mutation or pathogenic variant could occur in any part of the gene. So what is celiac disease? All of you know celiac disease is a complex genetic disorder, and therefore cytogenetic and molecular modality used for single gene disorder and chromosomal abnormality that we mentioned is not working here, and we will tell you later how it will work. It is autoimmune systemic disease. It has gastrointestinal findings like diarrhea, malabsorption, abdominal pain, and distension, bloating, vomiting. I am sure during the conference you will hear a lot about the clinical characteristic, and non-gastrointestinal findings including dermatitis, joint pain, and so on. The molecular pathogenesis of celiac disease is really interesting, and as I told you, it is interaction between environment and the gene. So usually the environmental factor and genetic factor influencing the disease by increasing intestinal permeability and overall immune response. So it is caused by immune-mediated response to gliadin, which is some component of gluten. In genetically susceptible individual, it will lead to inflammation of the small bowel, villus damage, and malabsorption. And the haplotype across HLA-DQA1 and HLA-DQB1 known to be associated with celiac disease susceptibility are necessary but not sufficient to cause the disease. The etiology of many of the extraintestinal manifestations not yet understood. Other genes, many involved in immune system or in intestinal permeability and environmental factor are play important role. In fact, 40% of Europeans are positive for HLA-DQ2 or HLA-DQ8, but only 33% of these individuals develop celiac disease. This indicates that human leukocyte antigen variants are necessary, but not sufficient to develop celiac disease. And after we complete the Human Genome Project in 2003, this gives us opportunity to study celiac disease over the world well, because now we have the database for the human genome of patients with celiac disease. However, in Arab population, still we don't have this database because we are not entered in the Human Genome Project, so it's mainly Caucasian database. So far, what is discovered that HLA genes is that if these are present, it is involved in the pathogenicity of celiac disease. So we have HLA-DQA1 and HLA-DQB1, and these class 2 histocompatibility antigen, alpha-1 chain and beta chain, and it is proved their pathogenicity is increased susceptibility to celiac disease. So the pathogenesis of celiac disease is involved adaptive and innate immune response. Once gluten is ingested, the protein peptide gain access to the intestinal lamina propria and increase permeability, and this will be recognized by antigen-presenting cell through HLA class 2 molecule, and finally trigger the CD4 plus T cell mediated immune response. And then creation of peptide, a human leukocyte antigen complex on antigen-presenting cell is responsible for transcription, configuration, and signaling preference involved in celiac disease pathogenesis. We should know that human leukocyte antigen molecule composed of two subunits, as we mentioned, alpha and beta, and account for 40% of genetic celiac disease variant. And if we go deep, the strength of immunological response is given by DQA105 and DQB102 dosage on antigen-presenting cell. The study shown the majority of people affected by celiac disease have DQ2.5 gene, and we know currently there is some therapy targeting this DQ2.5 gene by doing the CRISPR editing in order to have a gene therapy for celiac disease, but still this is under research. DQ2 haplotype are associated with early onset of disease, while DQ8 are associated with late onset of the disease in adult and older children. Also, this is insufficient and costly. HLA class 2 genes are the strongest risk biomarker for celiac disease development from the genetic point of view nowadays. So these are the one discovered and proved so far. So what is the genetic disorder associated with celiac disease? There is Down syndrome, which is trisomy 21 in around 5 to 12%, Turner syndrome in 3%, Williams syndrome in 3 to 10%, selective IgA deficiency in 2 to 10%, insulin-dependent diabetes in 6% of the cases, Sjogren syndrome in 5%, and autoimmune thyroid disease in 4% of the cases. And as we said, it is multifactorial disease, so it will not belong to a certain mode of inheritance. So it is not autosomal recessive, it is not autosomal dominant, or it is X-linked or X-linked dominant. It is multifactorial. So the answer, it will increase the risk in the family member. So and also the risk of developing celiac disease based on HLA diplotype, as we mentioned, it depends on the DA and DQ2 diplotype. For example, here the DQ2 plus DQ8, the risk is 14.3%, and in DQB102 plus DQB102, the risk of 3.8%, and so on. So we need to evaluate the relative at risk with patients with celiac disease. Actually, the answer yes, because they have increased empiric risk. So the parent usually the risk between 5 to 10% if it is unknown. If it is DQ2 positive or DQ8 positive, it is increased over the population risk. The sevoflurane of the index case, also there is a risk of 7% to 20%, the empiric risk, and the offspring around 5 to 10% empiric risk. If it is positive DQ2 or DQ8, it is increased over population risk. As we know, all the diagnosis by serological testing and the clinical finding, which is include tissue transagglutinaminase, anti-deaminated gliadin, and endomysial antibody, characteristic histologic finding on a small bowel biopsy, and the human leukocyte antigen haplotype DQ2 or DQ8 identified by molecular genetic testing of HLA DQA1 or HLA DQB1. This is a very interesting site I want you to know today. It's called the Genetic Testing Registry. You go and just type there celiac disease, and you will see all the lab that doing testing for celiac disease, and also the type of test. So you could choose whatever test you want to order and send it to the lab. So here we have 41 labs over the world doing testing, genetic testing for celiac disease, and usually they do gene panel for the discovered variant that increase susceptibility to celiac disease. And as you know, this variant increasing and increasing every year. So the question always raised in complex genetic disorder, it is not single gene disorder. So therefore, how to study it from genetic point of view? يعني لو أخذناها in general, if you have, for example, juvenile idiopathic arthritis, rheumatology, or let's say diabetes or celiac disease, how to study these from genetic point of view? Because if you do whole exome sequencing, like you send it, for example, to Syntogene lab, it will come negative. If you do whole genome sequencing, it will come negative, unless you tell them, please look for me for DQA1 and DQ and so and so. Then they will look at it, maybe they will discover it, but the regular test will come negative. So how to study that? This is, we call it in genetic GWAS studies or genome-wide association study. And usually we take the patient DNA and non-patient DNA and compare the difference to discover the SNP associated with the disease. And we discovered many non-HLA genes through this modality. So currently the proven one now, CTLA4, interleukin 2, PTBN22, and SH2B3. All these discovered through GWAS study, and also other loci now of interest around more 40 loci. So again, GWAS study, you take the cases and you take control, and then you compare them and see where is the difference and contributing to the disease development, and then you can conclude this is interesting area, so it is more susceptible to this disease. However, the problem with GWAS study, it cannot prove causality unless found in large cohort of individual, several ethnicity, and different several studies. So, for example, the QA1 and the QA2 was not proved until done in many different GWAS study and proven it is increased susceptibility to celiac disease. So it is really subjected to information and selection bias. So you need to have more larger cohort with many different study to improve the precision of your conclusion. So this is one of the GWAS study. So they comprise 12,041 celiac disease cases compared to 12,000 control from 7 geographic regions in Europe, including British and France and Portugal and Spain. And they found 13 new celiac risk loci. So it's very interesting actually to do something like this in Arab region and do from all Arab region like celiac disease patient and take control and see where is the loci in Arab region. Again here they identify in other study around 40 susceptible loci that increase risk of celiac disease. So here also another GWAS study, they test the non-HLA celiac disease SNP 39, which is mentioned previously, and they found that these loci SH2B3, ATXN2, ITGA4, IL2, IL21 associated with disease after 7 years of age, while TLR7 and TLR8 loci associated with disease earlier, before 7 years of age. And also they found SH2B3, ATSCN2 loci associated with type 1 diabetes. So recently, several studies have shown that the amount of gluten consumed by infants may affect the age of onset of celiac disease in genetically predisposed individual. New guidelines from European Society of Pediatric Gastroenterology, Hepatology, and Nutrition allow serology-based celiac diagnosis, omitting endoscopic biopsy in children, and do genetic study instead. Recent data and updated guideline in adults no longer support biopsy in all patients who are genetically susceptible with celiac disease who have been identified by serology with a clinical sign and symptom of celiac disease. Interesting medication, litiglutenase, orally administered mixture of two gluten-specific recombinant proteases that degrade gluten protein into small particles, and currently in phase 2 trial. And recent study described a mouse model that is characteristic of celiac disease. So in conclusion, celiac disease is a systemic autoimmune disease. It is complex genetic disorder, multifactorial. So very important to understand this concept. Complex genetic disorder, multifactorial. Genetic confirmation is not necessary for diagnosis of celiac disease, but it is supportive. Gene panel for a human leukocyte antigen haplotype, including DQ2 or DQ8, HLA, DQA1, DQB1, and other loci are the way to go for molecular diagnosis. And I show you the site where you can order the test from it. GWAS study have made significant progress in identifying association with celiac disease, and this is very interesting research project for Arab region. However, they have limited causality. The diagnosis of celiac disease is clinical in addition to serology and histopathology. Finally, I want to introduce the Journal of Biochemical and Clinical Genetics, which is official journal of Saudi Society of Medical Genetics, currently entering the third year this year, and we are applying for PubMed indexing hopefully by the end of this year. We need support from you, so please, any genetic gastroenterology data, we will be very happy to publish it in this in our journal. Thank you very much.
Thank you very much, Prof. Majid, for this amazing talk and review about the genetics in celiac disease. The floor is open for any question. Dr. Dhafir?
There is no question in the Q&A answer in the field. Please, if you have any question, just post it in the Q&A, please.
So in the Q&A on the page of the Zoom, you will find it, the Q&A question. So Dr. Majid, I have a question about the recently updated guidelines for omitting the endoscopy to do the genetic testing. Is there most of the people asking about the cost of the genetic test, and is that enough to diagnose, since we have a lot of different loci and it's not only linked to the DQ2 and 8? So can you answer this question, please?
Yeah, this is an excellent question. Actually, if you have the classical clinical finding, if you have the serology, finding confirmed already with tissue transglutaminase and endomysial antibody and so on, the serological biomarker, and you have the genetic testing also, then this is enough. You don't need to go to an invasive procedure. However, again, this is depend on you as a gastroenterologist. You are the most expert on this, so you will decide whether to go. But what I am saying that now genetic testing could replace the invasive procedure in some of the classical cases.
So we have question from Dr. Ali Al-Muhaidib about, do we need to do HLA typing routinely in celiac disease, especially when you illustrate, Prof. Majid, that only 3% they will get a positive result?
No, not routinely. Again, as I mentioned in the conclusion, it is a clinical, then a clinical, then a clinical, supported by serology, biomarkers, and endoscopy. But again, if you have it available and you have the cost, and I mean, the life is easy for you to order it, why not? I mean, this will helpful to differentiate and again to study the patient more from the genotype, phenotype. However, I think in our region, we need to go and do more in-depth study to identify these loci, because maybe the things that are true in Europe is not true here, because we have different ethnicity. So until that time, we should stick to our guidelines and our clinical approach in these cases.
Excellent. Prof. Majid, a question about, from genetic point of view, any relation between celiac and Crohn's disease, inflammatory bowel disease?
Well, both are complex genetic disorder. So again, I mean, environmental and genetic factor play important role. However, there is no clear relation between them until now.
Excellent. Thank you very much, Prof. Majid. We thank you for this talk and excellent presentations about the genetics of celiac disease. It was an honor to have you with us as a first speaker. Now we will move to the second speaker, who is our colleague, Dr. Abdulrahman Rashid, a pediatric rheumatologist who will talk about celiac disease and autoimmunity. Dr. Abdulrahman Rashid is the director of the fellowship program for the pediatric rheumatology in CASH, National Guard Hospital in Riyadh. Please, Dr. Abdulrahman, join us, and we are all listening to you now. Thank you.
Thank you very much, Dr. Maher. Hope my voice is clear. I would like first to thank the organizing committee for giving me this opportunity to talk about celiac disease and autoimmunity. My objectives from this talk is to recognize common autoimmune diseases associated with celiac disease with some of our local data. Also to understand that celiac disease is a systemic disease and a holistic approach is required. So it is a disease not affecting just only the gastrointestinal symptoms. And probably you will speak a little bit about this. So celiac disease, probably as all of you know, is a chronic immune-mediated disorders and it's triggered by the ingestion of a gluten in genetically predisposed patients. In terms of genetic, Dr. Majid has elaborated about this with the relation of HLA and non-HLA loci risk. The clinical spectrum is very wide and it includes a classic presentation of malabsorption, where the patient will present with pure gastrointestinal symptoms, with diarrhea, abdominal pain, abdominal distension, etc., and poor weight gain. Also, some patients, they may present with non-classic extraintestinal features, like skin manifestation, or like CNS manifestation, or like fatigue, or like other symptoms. Subclinical or asymptomatic form, and potentially disease with a positive serology with normal intestinal mucosa on biopsy. There is increased prevalence of other autoimmune diseases associated with celiac disease, and this is also including in their first degree relative as compared to control. And probably the genetic play a role in this context. The estimated burden of autoimmunity in celiac disease cases up to 15%. In celiac patients, an early diagnosis alive and having a family history of autoimmunity are both risk factor for developing other autoimmune disease, while the gluten-free diet has a protective effect. So it's very important to recognize them and to intervene early and treat them. By contrast, in relatives with celiac disease cases, the prevalence of autoimmune disease rises with age. On the other hand, a significant increase prevalence of celiac disease in individuals with autoimmune diseases. So it's not just only patient with celiac disease that they will develop other autoimmune disease, but also patients with other autoimmune diseases, like patients with diabetes, with type 1 diabetes, with thyroid or autoimmune thyroid disease, or patient with juvenile idiopathic arthritis. All of them, they have sort of risk to develop celiac disease, and probably they need frequent screening. This association among celiac disease and other autoimmune diseases may be explained by the sharing of common pathogenic bases involving genetic susceptibility. So in patient having genetic susceptibility like HLA, DQ2 and DQ8, they have risk for developing celiac disease, but as Prof. Majid mentioned, it's not enough. However, it's unimportant. Similar environmental triggers, and in case of celiac disease, probably celiac disease is one of the autoimmune disease that we know the trigger in contrast to other autoimmune diseases. So it will be triggered by gluten in the diet, and the basic pathogenesis of celiac disease is the loss of intestinal barrier, secondary to dysfunction of intracellular tight junction, with increased intestinal permeability, and possible by other mechanisms. The immunogenetics of celiac disease, I will just speak a little bit about the sort of pathogenesis. So patients with celiac disease have increased CD4 T cell response against several distinct gluten peptide, which recognized in the context of celiac disease associated HLA DQ molecules, especially DQ2 and DQ8. In addition, patients make antibodies specific for gluten protein, and probably one of the screening for celiac is transglutaminase antibodies, which has high sensitivity and good specificity. Another key aspect of celiac disease is upregulation of certain interleukins in innate immune system, and mainly interleukin 15, and maybe Dr. Mohammed Salama will elaborate more about this. So only cells that upregulate IL-15 and non-classic MHC class 1 molecules will targeted by intraepithelial cytotoxic lymphocytes. This is probably just a few slides about the pathogenesis. So there will be involvement of both innate and adaptive immune response simultaneously. So there will be a dual effect of both. So gluten peptides will exert like a stress on the enterocytes, which will release interleukin 15, and also the adjacent cells. They, as paracrine sort of action, they will release also more interleukin 15 through the NF-kappa B stimulation. So increased interleukin 15 will play a role for increasing the space between the enterocytes and increasing permeability. So the peptide will go into subepithelial area, and at that area will be recognized by the antigen-presenting cells, and antigen-presenting cells, especially those who express the HLA typing DQ2 and DQ8, will present them to the CD4 lymphocytes, and ultimately CD4 lymphocytes will activate the immune system through helper T cell number 1. again, in the pathogenesis, so we need a trigger, which is the gluten, in a genetically predisposed patient whom they have HLA-DQ2 or HLA-DQ8 in their antigen-presenting cells, and this will be presented to the CD4 lymphocytes. Also the indigestible gluten fragments, indigestible because gluten, it contains sort of proline, which is indigestible in the gut. So there will be more exposure to the enterocytes, and this will exert more stress, which will lead to this all immunological cascade, and will make the intestine leaky, and then will be recognized by the T helper cells, which will produce which will ask the B cell to produce antibodies against gluten, and also will ask the cytotoxic T cell to go and invade or cause the damage in the intestine. Again, this is another also probably the enterocytes, once they release IL-15, they also release another protein, zonulin, which also, if it's taken by the enterocytes, this will disrupt the junction and increase the permeability of the enterocytes to gluten, and will break the tolerance. Autoimmune disorders and celiac disease. There is a various autoimmune disorders occurring in patients with celiac disease. It can, a patient with sort of autoimmune disorder, they have risk to develop celiac disease. And on the other way around, patient with celiac disease have sort of risk for other autoimmune diseases. We have autoimmune liver diseases, especially autoimmune hepatitis, primary sclerosing hepatitis, primary biliary cirrhosis. Also, another common autoimmune diseases, endocrine diseases like diabetes, like thyroid disease, and to a lesser extent, Addison disease. Some dermatological diseases like Dermatitis Herbitiformis, which is, it seems to be related indirectly to gluten, and once you eliminate gluten, this manifestation will disappear. Also, alopecia areata, vitiligo, dermatomyositis, especially the dermatological manifestations. Neurological diseases like gluten ataxia and peripheral neuropathies, and this is also related to gluten antigen. Other also rheumatological disease like juvenile idiopathic arthritis, like Sjogren syndrome, systemic lupus, all of them, they have risk to develop celiac disease. And to a lesser extent also in rheumatoid arthritis, but it's less than the others. There is also other manifestation which may, the inflammation and autoimmunity may play a role, like dilated cardiomyopathy or autoimmune pericarditis and others. We'll go just briefly about each of them. So celiac disease is not only gastrointestinal manifestation. There is another extraintestinal manifestation, and those extraintestinal manifestation, they are related to the gluten and indirectly to gluten antigen. However, there may be overlap with other autoimmune diseases. So autoimmune liver disease, the liver changes were first recognized in 1977. Abnormal liver enzymes tests were detected in over 20% of celiac disease cases. So in patient with unexplained elevation of liver enzyme, it was estimated that up to 10% are due to celiac disease. So patients with unknown liver enzyme celiac disease should be one of the differential diagnoses. Mild liver abnormalities are common in patients with celiac disease and usually resolved with a gluten-free diet. However, patients with significant liver disease, they need more than just diet management. Association with autoimmune hepatitis, primary sclerosing cholangitis, well reported in the literature. The prevalence of celiac disease in patients with autoimmune hepatitis 3 to 6%, and estimated relative risk in children with autoimmune hepatitis of 6.6. However, reported prevalence of autoimmune hepatitis in celiac disease patient is less than 2%. So patients with autoimmune hepatitis, they have risk to develop celiac disease. And the other way around is a less pronounced that patient with celiac disease, they may develop autoimmune hepatitis. Celiac disease and autoimmune hepatitis share selected combination gene coding for class 2 HLA, and probably this is what will lead patient with autoimmune hepatitis to develop celiac disease. It has been noticed that patients with autoimmune hepatitis and celiac disease achieve treatment-free sustained remission in significantly higher proportion than patient with just isolated autoimmune hepatitis. And probably this tells you that the celiac disease, it has sort of effect on autoimmune hepatitis. And by eliminating the gluten from the diet, their response will be better. Moving to autoimmune endocrine diseases, and probably the well-known and common is type 1 diabetes. It's a well-known association. The diagnosis of both conditions is often simultaneously or maybe celiac disease subsequent to diabetes. The prevalence of celiac disease among type 1 diabetes is around 4% and is highest when diabetes onset in childhood, but also with long diabetes duration. The hazard ratio of 2.4 when you have celiac disease and subsequent risk of development of diabetes. The prevalence of positive celiac test result was 11.5% in diabetic patient in Saudi Arabia, and this is a study done recently and was published in Annals of Saudi Medical Journal. So testing for celiac should be offered to children with type 1 diabetes, especially if they have other features like poor growth or short stature or sort of other manifestations that could give you a hint for celiac disease. Celiac disease and type 1 diabetes shares HLA risk genotype. Approximately 90% of individuals with diabetes have either DQ2 or DQ8 compared to 40% of general population. In patients with both disorders, gluten-free diet prevents a growth failure in children and also better metabolic control of diabetes. Gluten-free diet have a protective effect on the development of vascular complications of diabetes. The second, also common autoimmune disease associated with celiac or celiac disease will develop in those patients is thyroid diseases. So celiac disease has a prevalence of 2 to 7% in patients with autoimmune thyroid disease. Thyroid dysfunction was detected in up to 10% of celiac disease cases. And the gluten-free diet does not protect from future development of thyroid disease, but by contrast, decrease of thyroid antibodies after 2 to 3 years or normalization of the thyroid function after 1 year of gluten-free diet has been reported. And also it has been demonstrated that tissue celiac antibodies react with thyroid tissue, and probably this is the pathogenesis why this disease occurs sometimes together. There also, to a lesser extent, and a few reports about Addison diseases in patient or celiac disease in patient with Addison disease. Moving to autoimmune dermatological diseases, and probably the well-known is Dermatitis Herbitiformis. It is a chronic inflammatory skin disease manifested by intensely pruritic polymorphic skin lesion with chronic relapsing course. And it is presence is characteristic of celiac disease, and lifelong gluten-free diet very helpful in treating dermatitis herpetiformis. So it seems there is indirect relation between dermatitis herpetiformis and gluten protein. It occurs in 25% of celiac disease patients. It manifests as erythematous papules, urticarial plaques with overlying vesicle or blisters, which may lead to erosion or excoriation. It affects both sides, bilateral extensor surfaces of knees, elbows, shoulders, midline back, buttocks, and sacral region. And one of the uncommon presentation of dermatitis herpetiformis, they may present as purpuric or petechial rash on the palm or the plantar surfaces, especially in children. Other dermatological feature or diseases that associated with celiac disease, alopecia areata, and patient with alopecia areata, they have risk to develop celiac disease. And the same thing for vitiligo. Autoimmune neurological diseases, and probably the well-known is gluten ataxia. It is a sporadic ataxia triggered by ingestion of gluten with positive anti-gliadin antibodies with or without enteropathy on duodenal biopsy. The disease presents with pure cerebellar ataxia or rarely in combination with myoclonus palatal tremor or opsoclonus myoclonus. And it was found that 36% of idiopathic sporadic ataxia is caused by gluten ataxia. 72% of these patients, they have HLA-DQ2. But only 24% had gluten-sensitive enteropathy. So patients, they are not necessarily to have GI symptoms, and only 13% reported GI symptoms. The pathogenesis is speculated to be antibody cross-reactivity between antigenic epitopes on Purkinje cells that found in the CNS and gluten proteins. And the post-mortem analysis of brain tissue showed cerebellar IgA deposits that contain trans aminase or trans glutenase 6. And this antibodies has been seen that their titer diminished or disappear with gluten-free diet. So this manifestation is related to celiac disease. And is one of the extra-intestinal manifestation. Early diagnosis and treatment with a free gluten diet has a better outcome before irreversible injury happen, because as you know, once it attacks the CNS cells, it will cause damage to the cells, and then the damage will be irreversible. So it's very crucial to recognize this early and start treatment. Same thing for peripheral neuropathy. It is, and usually when it occurs, it is symmetrical sensory motor axonal neuropathy, usually present with burning, tingling, and numbness of hands and feet with distal sensory loss. Gluten sensitivity may be the etiology in 34% of cases with idiopathic neuropathy, with prevalence of biopsy proven celiac disease at least 9%, and also presence of HLA type associated with celiac disease in 80% of patients. Conversely, prior polyneuropathy is a risk factor for celiac disease with odds ratio of 5.4%. Antibodies, the pathogenesis of the or the neuropathy, antibodies to gangliosides and Purkinje cells have been reported in celiac patients with the neuropathy and also in ataxia. Early diagnosis and the treatment can stabilize and improve the neurological manifestation, although this effect has been not seen in all cases, because once there is irreversible damage happen, you could not reverse it. There is also association with other inflammatory brain disease, specifically demyelinating disorder, and the estimated prevalence of celiac disease in patients with multiple sclerosis was almost 11%. And the long-term response to diet is not clear in those patients. So you may need also immune suppressive plus the gluten-free diet. Rheumatological disorders and connective tissue diseases. Probably the common one, SLE and Sjogren syndrome, and probably you know that Sjogren syndrome, they present with Zika manifestation, where patients, they have decreased tearing, decreased salivation, so they would have recurrent dental caries and dry mouth. Also, they have other manifestation like recurrent parotid inflammation, like joint manifestation, skin rash, and also other manifestations. And it's related to anti-SSA and anti-SSB. SLE, you know, it is a multisystemic disease. It could attack any organ from head to toe. It could involve brain, it could involve kidneys, joints, heart, every almost system could be involved in SLE. And the basic pathogenesis is anti-nuclear antibodies directed to nuclear antigens and causing the damage. And it is an immune complex disease where there will be activation also of a complement system. The celiac disease patients have threefold increased risk of developing lupus. The association of celiac disease in lupus patient has been frequently reported. 17.6%, and this is a local study, 17 from King Faisal, 17.6% of juvenile lupus patients have positive celiac disease serology, but normal histology, and they found that it has no relation to lupus disease activity. And in their conclusion that probably no need for doing celiac disease serology in patients with lupus, as it would not affect the disease activity. However, in another study in Egypt, where 10% of 100 juvenile SLE patients, they have positive tissue transglutaminase antibodies, and 6 out of them with positive biopsy. And in this study, they found a relation between the antibodies or celiac antibodies or celiac serology and lupus disease activity. So they recommend to measure the celiac in those patients. Juvenile idiopathic arthritis, they manifest with joint swelling. This is the hallmark of this disease, with absence of other etiologies, usually arthritis for at least 6 weeks. And the diagnosis based on exclusion of other etiology. There is several subtypes of juvenile idiopathic arthritis, like polyarticular, where there will be 4 joints involved, or less polyarticular if there is 5 and more joints, or systemic juvenile idiopathic arthritis, where they have fever and skin rash plus the arthritis. So celiac disease has been described in patients with GIA with a prevalence rate of 2.5 to 7%, and a significant increased cases of GIA in first-degree relatives of celiac disease patients have been found. Celiac disease positive serology was found in 42% of patients with GIA, 18 out of 42. However, the histology finding consistent with celiac disease was found only on 1 patient. This study was, I think, Dr. Al-Mahidib, part of the authors, and it was published in 2003. So there is extra-intestinal manifestation of celiac disease with rheumatic disease overlap. So patient may present with fatigue, arthralgia, back pain, skin rash, headache or anxiety, peripheral neuropathy, with the signs of iron deficiency anemia, arthritis, sacroiliitis, osteoporosis or osteopenia, and some nutritional deficiency. Those manifestations, they may be due to as extraintestinal manifestation of celiac disease. However, it could overlap with rheumatic diseases. So once a patient is having joint symptoms, it's better to probably refer them to rheumatology, and also the vice versa, where patients with rheumatological disease, they have sort of risk for celiac disease. And also it was found in that study, in the 2003 study, when patient, once they eliminate the gluten from their diet, their arthritis has improved significantly. Other diseases which may have also autoimmunity in nature or inflammation, like dilated cardiomyopathy, like pericarditis. Also in patients with psoriasis, and they found that or reported patient may improve their skin disease or psoriatic skin manifestation, they may improve with a gluten-free diet. Also, sarcoidosis, they may have risk to develop celiac disease, and also in idiopathic thrombocytopenic purpura, and there is association reported in the literature. So basically, any autoimmune disease, they have risk for celiac disease. However, the vice versa is a little bit less pronounced. Patient with celiac disease, they may develop other autoimmune in the future. In terms of screening, so patient with symptoms or signs consistent with celiac disease or at high risk of celiac disease, especially those with positive family history, type 1 diabetes, autoimmune thyroid disease, or Down syndrome, it's advised to measure total IgA and IgA tissue transglutaminase, which is probably the high sensitive test. If it is positive, they refer to GI probably for further testing and endoscopy. If it is negative, do total IgA, because they may have IgA deficiency. If it is, if the IgA is low, you may measure the IgG of the tissue transglutaminase and other deamidated gliadin peptides. If it is negative, so celiac disease is unlikely. Same thing if they have negative tissue transglutaminase and their IgA is normal, so celiac disease unlikely. If the symptoms persisted, then refer them to GI. And also consideration for doing HLA, DQ2 and DQ8 testing, because this may predict also patients with autoimmune disease if they will develop celiac disease. So in conclusion, celiac disease is a systemic disease that affects many organs. Patients with celiac disease have risk for other autoimmune diseases, and vigilant history taking and physical examination and maybe laboratories are important for early diagnosis and management. Patients with other autoimmune diseases have risk for celiac disease, and gluten-free diet may help in their management and probably controlling of their autoimmune disease. And multidisciplinary approaches are crucial in those patients who develop or who have celiac disease and other autoimmune disease. And thank you for your listening. I'm happy to take any question.
Thank you very much, Abdulrahman, for this awesome presentation, as usual, with very deep knowledge about the autoimmunity as a trigger for celiac disease. A great talk as usual, Abdulrahman, and if you allow me, there's a few questions. before we go to the break. There is a question from one of our colleagues about, can celiac disease patient have positive serology for ANA and asthma?
Well, yes, they could have. However, ANA by itself does not mean that this patient will develop like lupus. So ANA, as it is very has a high sensitive, it's a high sensitive test. However, the specificity is very low. We do also see ANA in normal population. So probably you have to put those tests in the context of the clinical manifestation. Probably the clinical manifestation is more important than just the labs.
Sure. Now, Abdurrahman, the audience is almost 1,000 attendee of this talk. So I have too much questions. So I'm sorry that I cannot offer all the questions for the speaker. A question about, as you know, it's more common in women, the autoimmune diseases. Is there anything about fertility in women with celiac disease?
It has been, I saw few reports, but I am not sure about really the correlation or the pathogenesis. I didn't go into deep in this matter.
Sure.
So I just mentioned the common autoimmune disease.
There's a good question, Abdurrahman, about if a child diagnosed with celiac disease in a gastroenterology clinic or general pediatric clinic, which autoimmune disease he should or she should screen for?
Well, first, you have to depend on so for patient with celiac disease, they have risk for other autoimmune diseases, but it's not that high. So I would say go with your clinical suspicious. Probably diabetes and autoimmune thyroid disease, they may have higher risk than the other autoimmune diseases. Like for rheumatological diseases. Rheumatological disease, you have to go first with your clinical. But for screening, yes, diabetes and thyroid or autoimmune thyroid disease.
Sure. A question from attendee who said that from your presentation, Dr. Abdurrahman, there was a few articles about patients who get autoimmune disease, autoimmune disease, and then they did the serology came positive. When they did endoscopy, the endoscopy came negative. So is that make, as usual, the autoimmune serology test is not that enough to diagnose, or is there just accidental finding of celiac, or it means that the celiac antibodies is useless in autoimmune disease?
Probably in the real life, we refer those patients to your gastroenterology. So probably you will tell us the answer. But I found like lupus, they may have false positivity of some serology to celiac. However, in terms of management, probably Maher, you will talk about this in your speak. There is a debate about asymptomatic patients.
Sure, perfect. I think we should stop now for the break. Thank you, Abdurrahman, again for this awesome presentation. And all the, I would like to ask the attendees to we will stop for 15 minutes. This will be for coffee break and pray for some areas in the kingdom. And inshallah, we will be sharply 7:30 with very dense 2 lectures about pathology and immunology. Thank you again, Abdurrahman. Thank you.
Thank you.
قعدت معك. Again, all respectful audience, we are now breaking for just 15 minutes for the coffee. We will be shortly by 7:30 with a very interesting talk about immunology as well pathology. Just keep yourself ready, inshallah, with a cup of coffee. 15 minutes will we rejoin the meeting. Thank you very much. Bismillah ar-Rahman ar-Rahim. Back to the symposium. And in this session, we have two awesome speakers. The first one will be Dr. Muhammad Al-Salama, who is the consultant pediatric allergist immunologist and assistant professor of pediatric in King Saud University for Health Sciences in Cash National Guard Hospital, Riyadh. He will talk about the wheat proteins diet and innate immunity in celiac disease. I would like all of you to welcome Dr. Muhammad, and please, Dr. Muhammad, if you can share your slide with us.
Assalamu alaikum. Thank you, Dr. Maher, for this introduction. And I would like to congratulate the people in Eastern Province for this amazing initiative for celiac disease. All right, so my talk will be, as it's stated in the title here, wheat diet and innate immunity. I have nothing to disclose, and my objectives will be the following. Upon completion of this session, attendee will be able to comprehend the following. One is the concept of innate and adaptive immune system interaction, central and peripheral tolerance, and how do they play a role in autoimmune diseases. Second is to explain what are the HLA genes. It's a very common things we see in diseases and associated with this multiple autoimmune diseases. So I'll be explaining what is the gene structures and how does that play a role in the immune system. The second half of my presentation is to go specifically about celiac disease after we have a strong foundation about the immune system and HLA genes. And then we're going to talk about how gluten, HLA DQ2, HLA DQ8, and the immune system predisposed celiac disease. And we'll touch base about some novel players in celiac disease pathophysiology, particularly in the last 4 to 5 years. So let's start with the, brief slides about what's the innate, what's adaptive immune system, just to put everyone at the same level. As we remember from our medical school, our immune system is divided into innate and adaptive. The innate immune system is not specific. It does not generate memory, but its immediate response and the subsequent response is usually not that much of stronger than the first response. The innate immune system is not just the antigen presenting cell. It starts from your skin, your gastric mucosa, the acidity of the gastric mucosa, the epithelial barriers, digestive enzymes. All of these are part of the innate immunity. Whenever there's a breakdown of any of these barriers, you are prone to infections. Now, in terms of the myeloid derivatives of the innate immune system, we've got the phagocytic cells such as neutrophil, macrophages, dendritic cell, which plays a big important role in the gut. B cell is also a type of antigen presenting cell, but it is part of the adaptive immune system, complement, and other proteins. While in adaptive immune systems, it's the B lymphocyte, the T lymphocytes, with all the subtypes of the T lymphocyte. That's beyond the talk of today. Now, with understanding these two immune systems, while in this picture they look like two distinct immune systems, they do interact significantly. A defect in one of the immune systems will impact the other one. So they are actually working in harmony together, and that's why when you have defect in one part of the immune systems, you're probably going to have impact on the other cell lines. Now, just particularly about the innate immune system, as it's my presentation today. So it's important to know it goes beyond antigen-presenting cells. Sometimes we only think about the innate immune system as just the antigen-presenting cells. As I said, the physical barriers such as, when you have a gastric ulceration, that's a breakdown in innate immunity, and that may lead to infections. It's the chemical barrier that we have, such as acidity, and that's how H. pylori evade that part of the immune system. And now the pattern recognition receptors, toll-like receptors, which play an important role in pathogen recognition. And then we also have the nod-like receptor, which is a very hot area in inflammatory bowel diseases over the last decade. and proteins such as complement, CRP, and innate cytokines. So all these are part of the innate immune system. Now, just an example of how they interact together. So let's say we have a pathogen. That pathogen will be recognized by pathogen receptors, recognizing receptors. And then when we have a phagocytic cells, it will be engulfed. Those antigen of the pathogen will be presented in major histocompatibility complex. That's an important term for the presentation today. And then when that antigen presented on the MHC complex on the antigen presenting cell, it will interact with the corresponding T cell receptors or B cell receptors, and that's how the innate interact with the adaptive immune system. But also the innate do secrete cytokines and chemokines that will stimulate the adaptive immune system, and also the adaptive will produce another cytokines that will augment the innate immune responses. So just a brief in how do they interact. The interaction of the dendritic cells with the T cells will dictate what kind of, plus the inflammatory medium around during the interaction will dictate how the T cells will differentiate. It could differentiate to T helper 1, T helper 2, T regulatory cells, and others. So now we just finished the part of what is the innate and adaptive. My next important talk is about how does autoimmune diseases develop. So let's start with the physiology first. Every day, million of immune cells graduate from the bone marrow. Those immune cells are not trained yet. They have to go to the thymus, and when they exit the thymus, 98% of those cells actually die and do never leave the thymus. So only 2% of your T lymphocytes that migrated to the thymus from the bone marrow will actually leave the bone marrow alive. The reason for this apoptosis, as you can see here, the major histocompatibility complex on the thymic epithelial cell play an essential role in selecting which T lymphocyte to survive, which T lymphocyte to die. And that's all based on if the T lymphocyte recognizes self-antigen, so for example, tissue transglutaminase, that T lymphocyte should die and never leave the thymus. If that antigen is neutrophil nucleic acids, then that T lymphocyte should not leave. So the only cells that does not recognize self-antigen are allowed to leave. However, there's a few cells that have a mild interaction or mild binding to self-antigen. Those will graduate as something called T regulatory cells. And the T regulatory cells express a very important transcription factor called FOXP3. This T regulatory cells that graduated from the thymus and recognize self-antigen, it goes into the periphery and ensure that if any other T cell that recognize self-antigen do pass the thymus without being deleted and escape to the circulation, we have a second line of defense, which is the T regulatory cells, to suppress this autoreactive T cells and try to prevent autoimmune diseases. If there's any defect at the thymic, at the Treg, other pathways, then the patient will be prone to autoimmune diseases. An example of a disease that affects the thymus and lead to autoimmune diseases is AIRE gene mutation, which is known as APOSID, which is multi-endocrinopathies, autoimmune endocrinopathies. An example of diseases affect the peripheral tolerance, which is IPEX, immune dysregulation, polyendocrinopathy, and enteropathy. It's related, there's no FOXP3, there's a mutation of FOXP3 leading to absence of T regulatory cells, and then they're prone to multiple autoimmune diseases. But also you can see here's the major histocompatibility. So certain polymorphism in HLA genes will give you different major histocompatibility complex. And if this MHC tend to present self-antigen as pathogen, then you're also prone to autoimmune disease. And we'll go and touch base on this one when we talk about HLA DQ2 and DQ8. The B cell also have the same characteristic, but rather than going through the thymus for the teaching and deletion for autoreactive cell, it happens in the bone marrow. So if you have any B cells that react to self-antigen, it should be deleted before leaving the bone marrow. If that does not exist, or there's a failure in to do so, then this B cell may escape to the circulation and produce antibodies against self-antigen, such as tissue transglutaminase, as an example. That's just another example in this process of lymphocyte going through the thymic, and then there's a negative selection for autoreactive and the production of T cells that should recognize only pathogen and not self-antigen. So all these examples of autoimmune diseases is a result of defect in self-tolerance. So systemic lupus, you have a defect in your B cells. For example, certain endocrinopathies such as type 1 diabetes and thyroiditis, it's related to T cells reaction against our own endocrine organ, leading to autoimmunity. So this central tolerance and peripheral tolerance has a very critical role in maintaining our body in homeostasis and not to generate any antibodies against our self-antigen. Any failure in that will lead to autoimmune diseases. Now, this is very important to understand the HLA genes and how do they play a role in the immune system. That will make you understand how HLA-B27 is related to inflammatory bowel diseases and ankylosing spondylitis. It will make you understand how DQ2 and DQ8 make predisposed patient to celiac disease. So before the human leukocyte antigen, it is the same as it's a synonym for major histocompatibility complex, which is in a human, we call it HLAs. And the reason for called in human leukocyte antigen is because they were first defined in white blood cells. We have 3 classes, but for the talk of today, we're just going to focus on class 1 and class 2. HLA class 1, which is responsible to, it's the genes that produce for us MHC class 1, major histocompatibility complex 1. In human, it's found in virtually all nucleated cells and platelet. HLA class 2 is restricted to APC, which is antigen presenting cell. We need to know HLA is one of the most polymorphic genes in human. The reason there is so many different HLA genes is to make us as a species, as as a human being, able to recognize any sort of microbial antigen and then fight it. So as a species, we could survive through multiple pandemics because we have such a huge polymorphism in HLA genes. So HLA located as in this paragraph in a human chromosome 6, HLA class 1 composed of HLA-A, HLA-B, and HLA-C, while class 2 is DQ, DP, DR. For celiac disease, our focus is going to be in DQ. For example, B27, it would have been in this area. So that's the gene. But the question is, how is this gene is related to autoimmune diseases? So those MHC class 2, so what we're going to focus, let's say, for example, we're taking DQ. The MHC class 2, for example, the DQ, you have this engrove here. That engrove is determined which protein you're going to be presenting to your T cells and how do you present it. So the transformational structure, not only the sequence of the protein, but also the shape of the protein and how is it presented to our T cell receptors and B cell receptors. Remember that this is the place where the antigen going to be loaded, and the down below is your antigen presenting cell. On the top here is going to be the T cell receptors, or the place where the adaptive immune will interact with the antigen. For celiac disease, for example, HLA-DQ2 and DQ8 has the tendency and the affinity to gluten. And that affinity to gluten makes it express gluten more than what should be expressed to T cell receptors, and that promote the autoimmune against present in celiac disease. Just one illustration. Remember, each one of us has 12 MHC in his cells. Let's say we're assuming this is an antigen presenting cell. 6 of them you inherited from your mom, 6 of them you inherited from your father. HLA and MHC, they have a very unique genetic phenomena, which is called co-dominant expression. There's nothing called, one is dominant, one is recessive. No, all of the genes, you're going to be expressing the protein. So you've got major histocompatibility complex class 1, which is HLA-A. You got one from your mom, one from your dad, and B, one from your mom, one from your dad, and C is one from your mom and one from your dad. And the same apply for DQ, DP, and DR. So that's just another illustration. So for example, in celiac disease, this is the HLA-DQ. It has a very strong affinity to gliadin peptide, make it and present it to the antigen presenting cells, and that lead to autoimmunity. A beautiful illustration is shown here. So let's say if I have any DQ other than 2 and 8, for example, DQ1 and DQ5 in this illustration, that my MHC complex will have a different shape than the gluten, which makes it very unlikely to pick up gluten and present it to your adaptive immune system. DQ2 and DQ8 has like a perfect match for gluten, which makes it prone to pick it up and hold it on the MHC complex to present it to your adaptive immune system, and that will start a cascade of autoimmunity. So now the illustration is here. We have a susceptible gene, which is HLA-DQ2, DQ8, and lack of T regulatory cells, which we're going to talk about it. Now, the patient eats wheat. The gluten will be not completely digested, and we're going to talk about it soon. That will be picked by antigen-presenting cell. Now, the gliadin is here. The antigen-presenting cell will present it in DQ2 and DQ8 to your lymphocytes, and then lymphocytes will be activated, and then there will be destruction of the epithelial lining and also B cells differentiation to B cells that secrete anti-TTG, anti-gliadin, and so on. Now, so we finished now the understanding of what is HLA and MHC. Now we'll just be focused on celiac, and that's my objective number 3. So, if I would think about it in my mind, why gluten in particularly? Why not casein and milk? Why not ovo, albumin, and egg? Why it is gluten? What is so unique about gluten that makes it recognized by HLA-DQ2, DQ8, and adaptive immune system, and then causing the epithelial damage and villus blunting? We already talked about why DQ2 and DQ8, but we'll talk about it more in details now. So what is gluten, first of all? So if we take the wheat flour, it composed from protein, starch, water, and lipids. But if we take the protein component, which only present 10% of the wheat, it composed from 3 different proteins, but 90%, the majority of it is gluten. And gluten is a combination of gliadin and glutenin. And what are the type of wheat? What are the type of food that contains gluten? Is the wheat, rye, and barley. So, and what is gluten made for? As I said before, so it exists in a polymeric glutenin. This is the glutenin, and a monomeric gliadin here. The gliadin has a very interesting structure. It is heavily composed of proline, which is the one in the P letter, and glutamine. The proline is resistant to gut enzymatic breakage. So compared to, or as opposed to other food or other protein, which is going to be break down significantly to very tiny peptides and amino acid, that's not the case in gluten. In gluten, you will have a significantly large peptide, One important characteristic about major histocompatibility complex and protein receptors, they don't recognize amino acid. They don't recognize tiny peptide that is less than 10 amino acids in length. They usually recognize something between 10 to 30 or above. That makes proline, that makes the gliadin in gluten is highly allergenic in that sense, because it cannot be digested, it's long, it can't be picked up by major histocompatibility and present adequately to your adaptive immune system. So the inability to breakage is one of the major reasons why gluten is problematic. The other important, just an illustration in A, your gut enzymes is unable to break your gliadin perfectly due to the presence of high proline. As you can see, proline, like every second or every third amino acids in gliadin is proline. So the inability to break it makes it long peptide chain, but now tissue transcontaminase do the second part in the pathogenesis, which deamidate, remove amide group from the glutamin. This removal will make it a negative charge, and that will make a high affinity to DQ2 and DQ8 in antigen presenting cells. So there are two unique characteristics. The large peptide due to the presence of proline, which is resistant to prolytic enzyme, and the effect of tissue transcontaminase and glutamine make it negative charge, and both those factors, the large and the negative charge, makes it high affinity to DQ2, a very critical process in establishing autoimmunity. So these are the two characteristics that present in gluten compared to other food makes it unique and makes it predisposed to celiac disease. So I ate, for example, if I am a patient with or prone to have celiac disease, I ate wheat. The wheat is break down into large peptide and cannot break down farther. Then it can be transported in under the epithelial cells in the lamina propria. Tissue transcontaminase will do deamidation of gliadin. Now it will be picked by your antigen presenting cell. Your antigen presenting cell has, when it's picked this up, it's matched perfectly on DQ2 and DQ8, as in the example in the key in the previous slides, and then we'll present it to an autoreactive T cell. So this T cell, which passed the central tolerance, should have been deleted in the first place. But because it's not, this was not deleted, and it react to or it react to gluten, which is a non-pathogenic component, this will be activated. What happened to the CD4 cells? It will get activated. It will produce toxic cytokines such as interferon gamma, as it thinks that now there's like an infection happening by mistake due to the recognition of gluten as a pathogen. The interferon gamma will cause destruction in your tissue, but it also will augment your dendritic cell. So when it augments your dendritic cell will be able to pick up even more gluten peptides, and again, more T cells activation. So you go into this virtuous cycle of picking up, activation, cytokine production, tissue destruction, again, picking up, and so on. But also that your CD4 is the cell that instructs your B cell to switch from IgM to IgG. Your B cell will, as with the T cell receptors, will recognize a gluten. It will pick up a gluten and process it internally and then present it to your T cells. As we remember, B cells is also an antigen presenting cell. But what's interesting, it can also internalize the enzyme tissue transcontaminase that is binding to the gliadin. And when it internalizes it, it breaks it down and then present it again and secrete antibody against your tissue transcontaminase. And that explains why patients with celiac have anti-gliadin due to the pickup of gliadin and anti-tissue transcontaminase due to the picking up of TTG2 by your B cells. Now, the question is, okay, we got it. We understand why gluten is being picked up and how DQ2 and DQ8. But what causes the destruction? Is it the antibodies? Is it your CD4 cell? Is it your antigen presenting cell? So that's what we're going to talk about it in the next few slides. So now the next question is, what is the effect of anti-TTG and anti-gliadin? We actually don't know if anti-TTG and anti-gliadin are causing destruction of your epithelial cells. We know it's present in celiac disease, but is it just a bystander, or it's actually the cause of the problem? However, we know certain anti-TTG is indeed associated with other diseases, as mentioned with Dr. Abdurrahman al-Rashid. For example, anti-TTG6 does seem to be a cause of ataxia, and anti-TTG3 does seem to be a cause of Dermatitis Herbitiformis and infertility due to trophoblast apoptosis. Then a question that comes to my mind, so if we say DQ2 and DQ8 will have a good affinity and ability to pick up gluten, so why not all patients with DQ2 and DQ8 develop celiac disease? For you to develop celiac disease, 3 things must present. 1, the gluten. 2, the antigen presenting cell that express DQ2 and DQ8. 3rd, this is what makes certain people with HLA-DQ2 have celiac and others not, is the autoreactive T cells. Without going into details, the T cell receptors is generated in a very random process. It's something called VDG recombination. Basically, what happened is there's a somatic genetic rearrangement in a way that in the T cell receptor, there will be just mixing of genes and you produce proteins. And you produce thousands and thousands, if not millions, of T cell receptors. One T cell receptor will recognize influenza. One T cell receptor will recognize a staph. One T cell receptor will recognize accidentally gluten. If that T cell receptor recognizes gluten, do escape to the periphery because of inability to be deleted by the central tolerance and peripheral tolerance by your Treg cells. This autoreactive T cells against gluten will wait for the opportunity of gluten to be presented on antigen presenting cell. So patient with HLA-DQ2 and DQ8, when they present gluten, and they do have, by their unlucky occasion, they have autoreactive T cells that recognizes gluten, now you have the disease. And that may explain, at least in a part, why not all patients with DQ2 and DQ8 develop celiac disease, because the presence of these are essential, but not enough. You do still have to have an autoreactive T cells against gluten. So now with this part, I talked about the adaptive, the HLA, and the MHC, and why gluten in particularly is a problematic. Now we talk about unique players in celiac disease. In the last 5 years, there's been a huge interest in interleukin-15 and a protein called NKG2D in mica. NKG2D in mica, these protein, when they interact together, it causes cell death. So that will take me to the next question. What is exactly the cause of epithelial damage and villus blunting? So when we have antigen presenting cell picking up gluten, as we talked previously, and presenting it to your adaptive immune system, its job does not end up there, but it's actually start to secrete cytokines such as interleukin-18, interleukin-15, and interferons. Interferons, they are known to inhibit your T regulatory cells. By doing so, it will decrease the T regulatory cells effect at the site. And that is probably because the dendritic cell thinks that it's picking up antigen. So it does not want any suppressive T cell. It only wants actually the active cytotoxic T cells, as it thinks by mistake that gluten is a pathogen. Now, when it produces IL-18, IL-18 responsible to recruit more cytotoxic T lymphocyte in the intraepithelial layer. The interleukin-15, which is there's been a huge interest in it, it enhances the expression of the NKG2D present on your intraepithelial lymphocyte. This protein will interact with mica, which is mica present in your epithelial cell, and it will cause self-apoptosis. And these two proteins are quite unique. It's not commonly seen in other pathway of apoptosis. The common one, the fast ligand, and granzyme B, these are seen in almost all cellular apoptosis. And those are also expressed by your intraepithelial lymphocyte, causing destruction of your epithelial cells. So now we understand how the tissue is destroyed. As in the past, it was thought it is the adaptive immune system that causes the destruction of your epithelial cell. Yes, it may play a role in it, but it seemed to be now the major player causing the destruction is actually your innate immune system due to the secretion of interleukin-5 and interleukin-18, and that directly will activate your adaptive immune system, and then through mica and NKG2D, cell death will happen at the epithelial cell. When there is cell death happening, there's more breakdown in your epithelial cells, more glutamine being transported through the lamina propria, more dendritic cell, more cytokines, and more killing activity. And this virtuous circle kind of continues. That was the IL-15, if you come across it through the papers, and NKG2D pathway. And that's a circle that I just repeated before, that the large size of gliadin and the deamidation that happens to it due to tissue transglutaminase will causes it to be picked up by antigen-presenting cell. The presence of DQ2 and DQ8 will present it, and the presence of autoreactive lymphocyte will interact to it. And you got these important cytokines and then cytotoxic activity and cell death. So last thing in my presentation, I would just highlight something on the horizon, which is might be going to be touch base in the future sessions, is the role of amylase trypsin inhibitors and toll-like receptor pathway. This enzyme is present in wheat, the amylase trypsin inhibitors, and it seems to inhibit the digestive enzyme that also add another issue of gluten breakdown. But also this enzyme seems to be directly stimulate your innate immune system and causes intestinal epithelial damage. There are certain microbiota, such as lactobacillus. This lactobacillus is able to break down or degrade this enzyme, and hence maybe the presence of this, or actually giving the patient microbiota, such as lactobacillus, may alleviate, at least partially, the symptom of celiac disease. Of course, we don't know this in a human yet. The studies has been done in mice and did demonstrate that mice model of celiac do benefit of adding microbiota in alleviating the symptom of celiac disease. So in conclusion, we have reviewed what is our immune system and how do we maintain the tolerance, the central and peripheral tolerance, and how that is important to regulate immunity and prevent autoimmunity. If T cell or B cell escape that pathway and recognizes gluten, that will be part of celiac pathogenesis. We also understand what is HLA gene and how HLA makes your major histocompatibility complex, the major protein responsible for presenting antigen to your adaptive immune system. If you do have DQ2 and DQ8, your major histocompatibility complex will have high affinity to gliadin, and that enhances the or predisposes to the celiac disease. We talked about how gluten is unique because of its high proline content, making it resistant to enzyme, and its negative charge that makes it high affinity to MHC. We also talked about how TTG increased the affinity of gluten to MHC. We talked about how the interaction between innate adaptive, the production of interleukin-15, 18, and interferon gamma result in epithelial death and downgrading of your T regulatory cells. And here is reviewing my objective as we talked about it. And with this, I conclude my presentation, and hopefully it's been helpful. And I'm happy to take questions from the audience. And thank you very much.
Thank you very much. Thank you very much, Mohammed, for this excellent presentation with deep knowledge at the molecular levels and subcellular level. It was amazing to get all the ideas about how the pathogenesis of the celiac disease is so complex. As you know, the audience is more than 1K and there is a lot of questions. Because of that time, we chose just 2 questions. So we'll start by question number 1. You mentioned that at the cellular level, there is more than 1 trigger and more than 1 stages of activation of the celiac disease. There is a question about which one is the most effective one or the most worsening one of the disease. They are meant by that in the future management or drug therapy. So which one of the mechanism you think is the more triggering?
Thank you very much. It's a very excellent question and very interesting question. So the problem with the immune system is, so we do know the innate play a major role, but is that only in the initiation phase? Because we do know once you activate your adaptive immune cells, you do generate memory. So is, like, for example, if I'm targeting the innate immune system, if someone already have celiac disease, could that help in also removing the adaptive immune system? So probably not. Probably the innate play a significant role in the initiation. But I'm not quite sure if we actually target that innate immune system will be able to reverse the pathogenesis, as long as there's an adaptive immune system already being activated. There are memory cells being created, and these memory cells, which is we don't know, but may stay forever or for the patient life. So it's I don't know which one of them will be the most critical one, but if I would guess, it would be the final pathway that causes apoptosis by MICA and NKG2D, probably because this is the final step. However, suppressing this or acting in this, we need to remember these are also important in killing neoplasmic cell. So if you actually play with the cytotoxic or killing ability proteins or the cell itself, then we need to think about, are we going to make patients more prone to cancers? Because that's also this is a tough balance, as it's also important in killing cancer and virally infected cells.
Sure. Another questions, Dr. Mohammed, about washing out T cell from the body. Do you think this is a future management?
I don't think so, because these patients, you actually you're giving them severe combined immunodeficiency. So we do have antibodies such as alemtuzumab and ATG will completely remove your T cells for 6 months or even longer. But basically, those patients without transplant, they probably will die. So it's not going to be maybe something, a very particular molecule, yes, but the whole T cell, I don't see it coming as a future treatment.
Sure. Last question and 1 comment. The last question is about the which is the bone marrow transplant. Since you are specialized in this sector, is there a treatment by BMT, which is very advanced to the celiac? But they are thinking that since those with carrier of this gene and they are prone to too much or too many diseases with autoimmune disease and some like Sjogren intestinal lymphoma or T-cell lymphomas, do you think that it will be in the horizon as a stem?
I do think so. Yes, no, and I think it's a very good question. We actually now, for certain autoimmune diseases, it's part of now transplant is an option, such as lupus. Bearing in mind, when you fix your immune system, you're probably not going to be able to fix your major histocompatibility complex that's present in your epithelial cells, in your thymus, and cells that are not belong to the myeloid or the hematopoietic. So your correction might not be incomplete. Plus the high lethality on it. However, things change in the futures, and transplant now we see it has way more indication than current time.
Thank you, Dr. Mohammed. The last one is the comment. There's a recent studies in stage 2, 3 for clinical trials with the using of microbiotas and ATIs for the treatment of celiac disease. Maybe inshallah tomorrow we will have talk about it.
Inshallah.
Again, thank you, Muhammad. Thank you very much. Amazing talk, and thank you for your time and the effort you did in our presentation.
Thank you very much. All the best. Thanks.
Thank you. Dear audience, we are moving now to the guy who is very busy, and we are always asking him to review our histology and histopathology specimen in the term of liver and GI disease in our hospital. Welcome to Dr. Fahad As-Sufyani, who is a pediatric gastrointestinal liver histopathologist. Dr. Fahad is running the pediatric pathology department in our institution in KMC National Guard Hospital. Dr. Fahad, thank you for joining us. We are making you busy, and we wish to hear from you what is going on when we send sample to you. Thank you, Fahad, and please join us.
Bismillah ar-Rahman ar-Rahim. Thank you very much, Dr. Hatlani. It's my pleasure to be with you today. I hope the screen is clear.
Yes, it's all good. Excellent.
Perfect.
Go ahead.
Thank you very much. So my objectives for today's talk is to start with normal duodenal histology. Then I will introduce a subject called malabsorptive pattern of injury in small intestinal biopsies. And then I will talk about the histopathology of celiac disease. And then I will end with the elaboration of some differential diagnosis of celiac disease. So let's start with the normal histology. This is the duodenal mucosa, and you can see from low magnification the nice villi. They are long, they are uniform, and they are lined by the enterocyte. They have goblet cells. So the compartment of the duodenal mucosa are four. The first one is the surface epithelium, then the lamina propria, and then underneath it is the crypts, and you have the muscularis mucosae. So I want just to point out an area called, or a term called crypt to villus ratio that we will talk about throughout this presentation. The crypt area, which starts from the muscularis mucosae until the base of the villus, this is the crypt, and the villi start from the base until the tip. So in normal, this ratio range from 1 to 3 to 1 to 5. So just keep this in mind. So when we see the other abnormal duodenal pathology. So next I will show you an image from the tip, and then I follow it an image from the crypt. So the tip, as you can see, consists of those enterocytes. These are columnar cells. They have abundant eosinophilic cytoplasm and lined by a brush border, which is very important to increase the absorptive capability of the duodenal mucosa. And also there are the goblet cells, which are secreting the mucus. And you have, these are actually highlighted some few lymphocytes. So the presence of few or rare lymphocyte in the intraepithelium is totally normal. And in the lamina propria, it consists of loose connective tissues, blood vessels, and usually contain few lymphocyte and plasma cells. So the presence of inflammatory cells in the lamina propria is normal. But if you see it in the stomach, for example, it's abnormal, indicate chronicity. So let me show you more or talk about the brush border. So the initial image, let me go back to it. This is H&E stain, which is called hematoxin and eosine. To highlight the brush border, we use another stain called PAS, periodic acid shift. So it's stain the brush border, so you can see it's uniform, linear, and also stain the goblets for us. And under electron microscopy, the brush border consists of microvilli. Usually they are thin and uniform and polarized. The rule of this, usually when you have a child, to evaluate actually the brush border with congenital diarrhea, for example, and suspect microvillus atrophy. Microvillus inclusion body disease, where those microvilli get lost and misplaced and form a microvillus in the cytoplasm. And this is where the name came, the microvillus inclusion, which is off topic of this interest in this talk. So next I will go to the phase of the crypt. So again, we have our enterocyte, basally located nuclei. We have our goblet cells. We have some few neuroendocrine cells. Look at the granules of the enterocyte. This is neuroendocrine cells. They are toward the basement membrane. While those two cells, they're called Banach cells. And look at the granularity toward the lumen. And this is, as Dr. Muhammad just mentioned about the innate immunity. This is part of the innate immunity. And they have some antimicrobial capability. So this is basically the normal histology. Next, I will talk about the malabsorption pattern of injury in the small intestine. So it's referred to a combination of three things. First, intraepithelial lymphocytosis, crypt hyperplasia, and villus blunting or atrophy. And this triad is the histologic hallmark of malabsorption in the small bowel and is frequently accompanied by clinical symptoms of diarrhea. These features can manifest singly or in a combination along a wide histological spectrum. So let me show you just an example. In comparison to the normal duodenal mucosa, you can see the villi become shorter, the crypt area enlarged, and this is what we call it crypt hyperplasia. And this results in the lamina propria, and in particular in the surface epithelium, it's increasing. So let's talk about the intraepithelial lymphocytosis. So it represents an immunologic process of crosstalk between luminal antigens and mucosal lymphocyte. And as I mentioned earlier, they are normally present in duodenal mucosa and has been reported up to maybe 23 intraepithelial lymphocyte per 100 enterocyte is within normal. So one key number maybe we need to remember is the 25 or more, which is required to call the presence of intraepithelial lymphocyte in the duodenum as intraepithelial lymphocytosis, 25 or more. So how we measure it? So usually we look at the tip of the villi and we count 20 enterocyte. And then we count the lymphocyte in these areas and we repeat it in 5 villi. Let me show you an example. This is a tip of lymphocyte. If you start from this enterocyte, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. 10 enterocytes, so this area, and we do the same in this area. So from this arrow to this arrow, we have 20 enterocytes. And then we count the lymphocyte. For example, this case, 1, 2, 3, 4, they reach 10. And make sure the lymphocyte above the basement membrane, not beneath it. Don't count the lymphocyte in the lamina propria. So in this example, this tip of villi contain 10, and you repeat it in other 4 villi, and you have the number of intraepithelial lymphocyte per 100 enterocytes. And remember why this is important, especially for celiac. Celiac usually affect the tip, so the number of lymphocyte usually at maximum level at the tip of this villi. Don't rely at the tip or the lateral aspect of the villi. So what do we mean by villus blunting and crypt hyperplasia? So crypt hyperplasia is defined as the elongation of crypt compartment. Crypt hyperplasia and villus blunting actually they goes hand in hand and frequently assist together and can be expressed as a crypt to villus ratio. So when the crypt compartment elongated and crypt blunting of the villi occurs, the normal crypt to villus ratio increase. Let me show an example. This is the initial picture that I show you. So almost like 1 to 4 maybe. But if you look at this biopsy, the Crypt to Villus ratio may be 1:1. And this case show really Crypt hyperplasia and maybe subtotal villus atrophy. So let's talk about the etiology of this pattern of injury. Is this unique to celiac? The answer is no. So this can be seen in medication. For example, NSAID, this is the most common, non-steroidal. Can be seen in reactive duodenopathy or small intestinal bacterial overgrowth, maybe non-gluten protein sensitivity or tropical sprue, or common variable immunodeficiency or autoimmune enteropathy. These all can show a more or less similar pattern. But let's talk about celiac disease. So celiac disease is an immune-mediated systemic disorder caused when exposure to gluten trigger inflammation in the small intestine in genetically susceptible individual. I don't want to go in details because my colleague, they really elaborate it, they discuss it. But just a reminder, it's need really a clinical pathological diagnosis. So appropriate clinical manifestation, specific celiac antibodies and genetic predisposed individual, and then the histological findings to confirm the diagnosis of celiac disease. So let's talk about the role of biopsy. So despite the advances in serology and genetic testing, adequate small bowel biopsy for histology remain critical for diagnosis and should similarly be obtained before instituting gluten-free diet. Furthermore, concurrent duodenal bowel biopsy increase diagnostic yield, since villus atrophy can be found exclusively in bulb in up to 13% of children and adults with positive celiac disease-specific serologies. So the recommended number of biopsies, 2 from the bulb and 4 from the distal duodenum. And they're recommended also to be submitted in separate container and usually submitted in a formalin fixative. So how about the histologic classification? There is a different scheme, but the one we use is the modified Marsh. And this grading system required actually a diagnosis of celiac disease and are best used as a method of assessing histologic improvement in sequential biopsies and or for research purposes. So let me show you the table that summarizes it. This is the modified Marsh classification. So lesion type, you have 1, 2, and 3. And we assess 3 compartments, the intraepithelial lymphocytosis, the crypt hyperplasia, and villus atrophy or blunting. So for lesion type 1 is the presence of intraepithelial lymphocytosis alone. For 2, in addition to the crypt hyperplasia. For 3, you have some degree of villus atrophy. If it's mild, this is 3A. If it's moderate, this is 3B. If it's severe, this is 3C. Okay, let me show you some example to make it easier to understand. So if you look at this duodenal biopsy, you would see the architecture is maintained, the villi is within normal range. So the only abnormality when you go really high magnification and you see the intraepithelial lymphocytosis. And this is modified Marsh type 1 lesion. Another example. So let's evaluate this one. From the muscularis mucosa, you have the sense there is a degree of hyperplasia, crypt hyperplasia. The villi not totally normal. There is also some degree of atrophy, maybe mild. And then when you evaluate the tip of this villus, there is again increased number of lymphocytes. And this will make it modified Marsh 3A lesion. Another examples, and it shows different or a severe degree of atrophy. This is subtotal, which is a 3B lesion. And this is actually one of the commonest that we see in practice, the 3C, the total atrophy. So almost, if you don't tell me this is from the duodenum, I will think like colonic, because there is no villi whatsoever. So let's talk about the monitoring. So monitoring of celiac disease is based on a combination of history and serology, and repeat upper endoscopy with intestinal biopsy is recommended in cases lack clinical response or showing relapse of symptoms despite a gluten-free diet. Patients who fail to respond to a gluten-free diet may have a non-responsive celiac disease, which is defined as failure to respond in the first 6 to 12 months, or refractory celiac disease, which is defined as a failure to respond for more than 12 months. So this scenario requires really a diligent re-examination of alternate diagnosis, like maybe another for food intolerance, or maybe the patient is non-complying with gluten-free diets. So a few words about the refractory celiac disease. So diagnosis of refractory celiac disease requires repeat small biopsy while the patient adheres to a gluten-free diet, and can be further divided into type 1 and type 2, which based on the histological findings. So in type 1 is identical to untreated celiac. So you have intravethial lymphocytosis, they are typically T cells, and they are CD8. But type 2 shows CD3 positive intraepithelial T cells that exhibit an abnormal lack of CD8 expression. And this is very important. So these T cells abnormality in type 2 refractory celiac disease are associated with significantly less favorable prognosis as compared to type 1. Transformation to enteropathy associated T cell lymphoma is a prominent risk and may require treatment by surgery, chemotherapy, or bone marrow transplantation. So the final segment of my talk is to talk about the other differential diagnosis of malabsorption pattern. Let me show you the slide of etiology. So basically, I will talk about those on red. So I'll start with the reactive duodenopathy. So it's often attributed to the increased acidity in the duodenum. And there are different causes. For example, H. pylori, this is the most common, H. pylori infection. Other causes like gastric heterotopia, or use of medication, or this syndrome. So what are the pathological findings in reactive duodenopathy? There is usually increased cellularity in the lamina propria with the plasma lymphocytic aggregate, maybe some neutrophilic infiltrate. And there is also reactive epithelium, which manifests as gastric metaplasia with or without prenal glands in the mucosa. There are also mild change that may cause non-specific malabsorption pattern, and when the reactive change becomes severe, an ulcer developed, and the term peptic ulcer disease may entertain. So let me show you an example. So this is a biopsy from the duodenal bulb. So you have relatively mild villus atrophy. By the way, the bulb, usually the villi are shorter than the distal. And the cause of that is because of the prenal gland usually more prominent underneath it. So don't rely on the assessment of the villus length in the bulb. It's better to be evaluating the distal from the biopsy from the distal duodenum. And we didn't mention that in the celiac, but celiac disease can be patchy. And this is actually the reason why we have multiple biopsy, which is maybe up to 6 biopsy. So in this example, so if you compare this epithelium here, which is the expected normal, with this one, this looks different. This is the typical called gastric metaplasia, which is in this high magnification furfular epithelium. So you have initially goblet cell depletion and then metaplastic change. Metaplasia means change of epithelial type to another. And again, there are some lymphocytes in the intraepithelial lymphocytosis. So in this example was due to H. pylori infection. Now the question, can H. pylori infection coexist with celiac? The answer is yes, not uncommon. But usually we rely on the distal parts, the other biopsies, and also in the appropriate clinical setting. You should have also some serological evidence and the clinical, but not uncommon to have both. So if you see something in the stomach, like H. pylori, and you see some finding intravitreal lymphocytosis, they could coexist together. So let's move to the small intestinal bacterial overgrowth, which is defined as the growth of anaerobic enteric bacteria, more than 1,000 from a duodenal aspirate. So what are the causes of small intestinal bacterial overgrowth? Decreased acid secretion, like patient on proton pump inhibitor, or motility, or anatomical abnormality, like a duplication of intestine or diverticulum, or altered gut immunity. So those patients experience bloating, diarrhea, steatorrhea, and fat-soluble vitamin deficiency. The histologic show non-specific malabsorption pattern that can range from very mild intraepithelial lymphocytosis to a total villus atrophy. And the gold standard to diagnose that is the culture of duodenal aspirate. So let me show you an example. So this is a duodenal mucosa, and as you can see, there is crypt hyperplasia, subtotal villus atrophy, and when you evaluate the tip of this villi, there is intraepithelial lymphocytosis. It's actually indistinguishable from celiac disease. That's why we keep repeating. Celiac is a clinical pathological diagnosis. So in this particular example, the duodenal aspirate was performed and showed increased number of the bacterial colony. Next is the non-gluten protein sensitivity, like cow milk protein that can cause hypersensitivity reaction. Clinically, usually present in infancy. The histology may be patchy, feature resemble celiac, but the different, usually we see increased number of eosinophils. Other differential, histologically, is a common variable immunodeficiency, which is a primary immunodeficiency disorder characterized by impaired B-cell differentiation with defective immunoglobulin production. It is the most prevalent severe antibody deficiency affecting both children and adults. So small bowel biopsy from patient with common variable immunodeficiency can display a host of non-specific feature, includes maybe villus atrophy, prominent intraepithelial lymphocytosis, apoptosis, acute inflammation, maybe even granulomas. And remember, those patients are immunocompromised, so maybe they have some opportunistic infection like Giardia, which raise the differential diagnosis of celiac disease, Crohn's, or even autoimmune. So what normally seen in the duodenal biopsy is the absence of plasma cells. And this is true in maybe up to 2/3 of those cases. So maybe 1/3 of those cases, we might accept a few plasma cells, but usually their number diminished. So let me show you an example of this. So almost total villus atrophy. Again, crypt hyperplasia. And if we go high power, we have also intraepithelial lymphocytosis. If you look closely to the lamina propria, although the resolution is not great, there is a very rare plasma cells. So this is a common variable immunodeficiency. The last topic is the autoimmune enteropathy, which is characterized by intractable diarrhea, not responsive to dietary restriction. Although primarily a disease of infancy, adult onset cases have been documented. And this disease is usually associated with other autoimmune diseases. So up to 2/3 of patients have mutation on the FOXP3 gene, which is responsible for regulatory T cell function. So what we see in pathology, usually the absence or reduction number of goblet cells and Bannet cells, and the presence of crypt apoptosis are diagnostic features. Clinically, the presence of goblet cells or anti-enterocyte antibodies is found in the majority of cases. So let me show you a case. So this is total villus atrophy, and what you can notice, increased cellularity of the lamina propria and increased number of intraepithelial lymphocytosis. Let me show you high magnification to show you something else. There is also apoptosis. And where is our Bannet cells? They are absent. So absence of Bannet cells, increased apoptosis, increased cellularity. This is autoimmune enterobative. So take home message. Celiac disease, as our prior distinguished speaker elaborated, is an immune-mediated systemic disorder caused by exposure to gluten protein. And it's always a diagnosis rely on a clinical pathological correlation. And the number of biopsy recommended is 6, 2 from bulb and 4 from the distal duodenum. And the histological feature are 3 intraepithelial lymphocytosis, crypt hyperplasia, and villus atrophy, but are not diagnostic in isolation. These are my references. Thank you for your attention, and I welcome your questions.
Thank you very much, Fahad, for this awesome presentations. You go through all the details about the pathological finding of celiac disease. We enjoyed the slides. We enjoyed the explanation, differential diagnosis, and it was a great talk as usual, Fahad. Dear Dr. Fahad, we have few questions. We will choose, because of the time, 3 or 4 questions. Question number 1 was about, is there any special stain for celiac disease when you mention about CD3-8 positive expression intraepithelial lymphocytes?
Well, some paper talk about the application of CD3 to detect the intraepithelial lymphocyte in celiac disease, but actually is not recommended. They are visualized by HNE. If you do the immunostain, maybe give you a false positive estimation. Just rely on your HNE. Have a good section, 4 micron in thickness, and HNE is enough.
Second question, Fahad, about with your experience as a gut pathologist, how common you notice malignancy with celiac disease?
Wow, this is extremely rare, usually in adult, not in pediatric.
Adult.
There is recent case of enteropathy associated lymphoma, actually, with our lymphoma team. They discussed last month. So it can exist, but usually present later in life, not in pediatric age.
Sure. There is a question about why celiac disease is a patchy disease by histopathology.
Well, this is a good question. Most of the cases, I see them virtually in each pieces, but I think the good detection, I see some cases, came from the clinic, patient is diabetic type 1, just for screening for celiac, you do your clinical assessment, and you do the serology, you find, borderline or increased now, abnormal serology. And in those cases that you detected early, usually I see the patchiness of celiac. But those is really established who present with really failure to thrive or anemia, these are too late, to be honest.
Thank you very much. The last question, if you allow me, is how common as a histopathologist you notice ulcers in celiac disease beyond March 4?
Wow, to be honest, these are rare. Sometimes, I see sometimes granuloma, and usually we question the diagnosis, to be honest. But rare. Sometimes I see a few eosinophils, not to that degree that I will think of allergy. I just describe it, and then the key actually communication with our team. What I see is just communicated. We follow with those with those kids, actually. This is the key. But ulcer, acute inflammation is okay. Few of neutrophil is okay, but ulcer, never seen.
Sure. By the end of this talk, thank you very much, Dr. Fahad As-Sufyani, more than 1,100 audience, really sending a lot of compliments to you for this excellent presentation. Thank you very much, Fahad. Thank you for your joining us in this symposium. By the end, I would like you to conclude this talk by today. We get 4 great speakers this afternoon and evening, and then we conclude our meeting. We wish to see you tomorrow at 6 p.m. for the second round of the second day. Looking forward to meet you, inshallah, tomorrow. Thank you very much for your attendance, and see you tomorrow. Thank you.
Dr. Maher, بس on the same link that it was sent to you previously, huh? For the
sure, it will be the same link. Yes, thank you.